Bore da bawb a diolch am ymuno gyda ni heddiw ar gyfer cyfarfod rhythwyr Bwrdd Ymddiriedolaeth Prifysgol Velindre. Good morning and welcome all to Velindre University NHS Trust Board's virtual meeting held in public. Byddwch yn gallu arsylwi y cyfarfod heddiw, ond ni fydd cyfle i chi gyfrannu. Rydym yn recordio'r cyfarfod a bydd copi ohono ar gael ar ein gwefan yn fuan. You join us today as observers, which means you cannot participate in the discussion. A video of the meeting will be available on our website as soon as possible. Cadeirydd y cyfarfod heddiw yw Cadeirydd yr Ymddiriedolaeth, yr Athro Donamid OBE. Mae 6 aelod annibynnol arall gan y bwrdd fel y gwelwch o'r wybodaeth ac gyflwynir. Today's meeting will be chaired by the Trust Chair, Professor Donamid OBE. As you can see from the slide, the board also includes 6 independent members. Yn ymuno â nhw, mae aelodau bwrdd gweithredol y Ymddiriedolaeth. Joining them today are the Trust's executive board members. Croeso hefyd I rai o'n partneriaid allanol. We also welcome some of our key external partners to today's meeting. Mae'r bwrdd yn gyfrifol am reoli perfformiad a strategaeth yr Ymddiriedolaeth. The board is responsible for the strategy and performance of the Trust. Bydd y cadeirydd yn agor ein cyfarfod yn awr. The Chair will now open our meeting.
Bore da, a croeso cynnes iawn I chi gyd y cyfarfod yma. Welcome everybody this morning. This is the September 22 public meeting of the Velindre University NHS board. I'm pleased to confirm, as you probably just heard, this meeting is being live streamed today. So you can join us remotely, some of you will have already, but a recording of this meeting will be available on the Trust website very shortly, and then members of the public or indeed our own staff can view the board at their convenience. So welcome everybody, whether you're online or in the room, welcome to you all. I have some apologies this morning from Stephen Allen, Chief Officer of the Community Health Council, from Gareth Jones, Independent Member, and from Katrina February from Audit Wales.
I just noticed Kate there.
Oh, Kate, are you there? Your name just, oh, Kate, you're here. I had apologies. Oh, welcome, Kate. So let's delete that. Very pleased to see you, Kate. And also Steve Ham, our Chief Executive. Are there any other apologies that I've not been made aware of that the colleagues want to report now, please? No? Thank you. And we should have in attendance today, I'll just check, I can't see the name on the screen yet. David Cogan, Patient Liaison Representative. David, are you here?
No.
No, so David, and Brenda Chamberlain from Community Health Council. I can't see Brenda either, but should they join us later, they'd be very welcome. And before I start the meeting, just a little snippet of information. You may, all of you recall, I know you read my chair's report diligently, taking on board every syllable, but I hope you'll recall at the July board, I reported on the National Healthcare Estates and Facilities Day. And we celebrated the work of our estates and facilities staff and everything that they do to make things run smoothly in the trust. And following on from that, I thought it would be helpful if the board could meet some of the staff. And so to that end, they will be joining us for lunch. And so more of that as we get closer to lunch break. So just thought I would let you know that. And it does also mean that I need to keep a very careful eye on the time so that that we end this meeting to coincide with them arriving, because they've got very busy jobs to get back to. So turning now to 1.30, declarations of interest. Are there any declarations of interest pertinent to the items on today's agenda which need to be declared? No, thank you. So if I can take you then please to 1.40, which is the action log from our last meeting, which was held on the 28th of July, 2022. You can see there that 7.20, the Cardiff Cancer Research Hub heads of terms are being supported by an external consultant, and we get an update at the November board. The trust enabling strategies for approval, colleagues, you'll remember the enabling strategies were approved, but board requested some draft case studies to be circulated. These are still being worked on and will be circulated very shortly. And therefore I can't see any other all other actions are closed. Are there any matters arising on the minutes which there's an action perhaps which we need to discuss here? I know we haven't approved the minutes yet, we'll come to that in a second, but if there's any matters arising not included on this action log, I'll take them now.
Chair, sorry. If I just go back to the open on the enabling strategies 510, just to inform the board they are complete and they're currently with the printers. We should be getting final products back next week, so then we'll share as per. So that has been achieved, so I was a bit slow off the mark there, I do apologise. And thanks to colleagues around the table for supporting that piece of work.
Thank you, Carl. So I'm sure we're all looking forward to receive. Will it get a wider circulation on the board, Carl? I'm sure they'll be very helpful.
Yeah, well, hopefully they'll be in our documents, but also one of the key channels of communication is online, so social media. So we're trying to bring them to life to make them meaningful. And there's a planned launch of all of those strategic documents, which Lauren and the team in comms are working on with a range of people. So again, we'll bring that back to the board for their input and their leadership role in that. Yeah.
Certainly the draft ones were very powerful when we looked at them in Strategic Development Committee, so I look forward to that.
Thank you.
So if we can then turn to section 2 of the agenda, which is the consent items. So this is a large section of the agenda. This section considers routine committee business as a single agenda item. But before we go down to the particular items, does any member of the board wish to pull something out of consent for discussion? If they could let me know now, we can decide where best to take that particular item. Does anybody want to pull anything out of consent? No, thank you very much. So then we go to 2.10. So the first item is 2.11, which are the minutes from the trust board. I'd like to congratulate the team preparing the minutes, because on this occasion I have to say I didn't have a single correction to make. When they were sent to me for approval, first of all, they were absolutely perfect, and so congratulations to the team for the excellent minutes. So 2.1, so they're approved. So 2.12, Chair's Urgent Action Report. So you're asked, colleagues, to consider and endorse the Chair's urgent action taken between the 1st of the 8th, 2022 and the 21st of the 9th, as set out in the appendix. Colleagues, you'll notice that my name isn't always there as an approver. Stephen Harris's name is there, was acting vice chair because I had to take a period of leave for personal reasons. So the board so they're approved. 2.13, colleagues, then commitment of expenditure exceeding the chief executive's limit. So we're asked to authorise the chief executive to approve the award of contracts summarised in the papers and the supporting appendices, and to authorise our chief executive to approve requisitions for expenditure under the named agreement. Andrew.
Couple of minor matters for accuracy.
Okay.
In the cover paper, which describes the cover paper, page 2.
2.1.3, isn't it? Yeah.
Yeah. The table, appendix 1, The start date, this is the WBS renewal of Welsh Blood Service liquid nitrogen supply. The start date is correct, but the end date is not. The end date is stated as 30th of September 22. I think it should be 25.
Which appendix number is that, please, Andrew?
So it's in the table for
The table
appendix
appendix
1.
one, is it?
Yeah,
Yeah.
yeah.
Okay, I'm
So
finding it now.
it's just a small error. It's correct in the appendix itself, I should say, but it's just a small
So,
typo.
colleagues, could somebody confirm that that should be 3923?
25.
25.
Yeah.
Okay, so we make that amendment. Thank you, Andrew.
Can I raise one more again, it's a minor detail. This is in appendix 2, the HLA tissue typing. It'd be really helpful to have an abbreviation list. We commonly do have them, but I had to look up what HLA stood for, and there are some others as well. As it would just be helpful to have a table of abbreviations. It would certainly help me.
I noticed there were 1 or 2 areas where I was looking things up as well.
Yeah.
So if we can ask our authors if they will make sure that the abbreviation list is complete. Because it's distracting, isn't it? You have to then go and look it up for yourself, and that can take you away for 10 minutes, and then you have to start again, don't you? So yes, that would be really helpful, and it's important for our public.
Exactly, and the other documents tend to have them as well, so it would seem appropriate here, given there's some technical terms in the document.
And the same thing here where right, so they're approved, and then we come to 2.1.4 trust-wide policies. I'm going ahead of myself. Here we are. So we've got a number of policies in here. The Workforce and OD policy and procedure, WF05, equality, diversity, WF44, working time, and then there's some annexures that the NHS Wales arrangements for pay and so on. So, oh, Martin, sorry.
Thank you, Chair. Just quickly on the equality, diversity policy. Very happy with the policy itself. There's a line in it at the top of page 6 which says specific policies will also be developed in due course to address particular strands of the Equality Act, which is great. I'm not sure that's a line to be in the policy, and I guess the
Where
question.
are you, Martin, please, so I can
Top
follow
of page 6, we're in the equality, diversity policy.
Top of page 6.
And as for good governance, I think due course is a little bit loose. But I don't actually think that line should probably be in the policy, if truth be told, because it means when those are developed, we'll have to change that line, won't we? It's helpful.
Can you respond to that?
Yes,
please?
absolutely. Thank you, Martin. I think you're absolutely right that that line should be removed from the policy. In respect of that work, clearly we will do that as necessary to respond to changing circumstances due to specific parts of the Equality Act. So we will remove that line from the policy.
So with that amendment, we're content to approve the policies that I've listed. Oh, is it doing now, my computer? That takes us to 2.1, 2.2 on the agenda, which is for noting. And the first one there is the Transforming Cancer Services Communications and Engagement update. So we note at communications update, and we note all of the activities that are taking place to keep both our staff and our communities both updated and engaged. And I would commend to you, I asked for this to be put on, the appendix to the communications updates, which is a note on the summer jamboree, which happened from the 10th of August to the 1st of September. There is a video, I think, that accompanies this. Or was this to do more with the young ambassadors?
There's press coverage, ITV News.
ITV News, yes, it was covered in ITV. It was a very, very busy and productive time with staff working over and above to make this something which was interesting. They injected it with enthusiasm. There were people involved who were patients and not patients, and some of the goals and outcomes are listed on this appendix that I've included with your papers. And you could see the timetable from the 8th right through to the end. You can just see how busy it was. We looked at this in quality and safety, I think, wasn't it, Vicky? We looked at this, and just is so amazing that and you know, those of us who don't have to organize these things wanted to know when the next one's coming, but we do appreciate how much work went into doing this. But I think that community members who attended, it was very positive from that point of view. They were able to see us, talk to us, be engaged in a number of the activities. So what I want to do here is to commend all the staff from sustainability, from comms. Am I missing anybody out?
And the project team.
And the project team,
Yeah.
who put this together. And there will be more, but we wait and see for a plan to come forward.
Yeah.
Well done, everybody. This was just absolutely amazing. I noticed the craft tent is still up.
It came down yesterday afternoon.
Oh, I was there yesterday afternoon. I didn't realise it was his last day.
This is last day.
Oh, right. So now we come to, that was 2.21, which we note. So we come to 2.22, and these are the highlight reports from our various committees. So the first one is Transforming Cancer Services Programme Scrutiny Subcommittee. So we note that. 2.23 is the, sorry?
We don't have a paper, it says to follow here.
If I can,
Oh, I thought it was they turned it around quickly.
they did. I received it yesterday, so there wasn't sufficient time to load it onto the board papers. So I can speak to it very quickly. If I
Yes,
think that'd
please.
probably be very
I don't know where I glanced at it. So
yeah, it's here on my screen, so I can talk to it. It didn't seem appropriate to be loading it up this morning, last minute. So I believe, Lauren, that the paper will be loaded onto the website and be distributed to board members after this meeting. But just say, unfortunately, you don't have it in front of you. Just two things I just wanted to draw out of the highlight report, both under Assure. So in terms of the TCS programme as a whole and the finance report, we received an update on the finance report, and that due to delays in the projects within the programme, we're likely to underspend by about £3.4 million on the capital provided by Welsh Government by the end of the year. So it's arrangements been put in place to hand that money back and then to receive it straight back in 2023-24. We don't have a facility, obviously, to carry money over ourselves. It's going to be passed back to Welsh Government and then immediately passed back to us in the new year. So we still have the total funding required. So that was an update on the finances. And then we also received an update on the Welsh Government's Infrastructure Investment Board meetings, which are considering the integrated radiotherapy solution business case and the radiotherapy satellite centre business cases. So that meeting was yet to occur when we met last week. I believe it has occurred in the meantime, but obviously we're looking to secure approval for those two business cases so we can continue to proceed with them. So that was the update we received a week or so ago. And maybe there is a further update which might be made known to us later in the meeting. I don't know, but
No,
not yet. Okay, that's fine. Yeah. So at some point we'll know the outcome of that meeting. Thank you. So those were the two things I just wanted to draw to the attention of the board in terms of the last public meeting of the TCS Scrutiny Committee.
Thank you, Stephen. I better make sure I'm looking at both my screen and my hard copies now, and to make sure I'm not actually. So next is the Quality, Safety and Performance Committee highlight report. So we note that. The Audit Committee highlight report and the Local Partnership Forum highlight report. And then Welsh Health Specialised Services Committee Joint Committee briefing, we note. And the NHS Wales Shared Services Partnership Assurance report, we note. Note also the Trust Seal report. My last board I worked with, we used to call this the affixing of the seal report. And I learned from that when you put a postage stamp on an envelope, you affix it. So every day is a learning day. So we note the Trust Seal report.
I know.
So that concludes the consent agenda. So just before I move off it, does anybody want to raise any items now? Just wanted to make sure. Yeah. So we turn to section 3 of the report, and the first one there is the Chair's update report. And I'm happy to take any queries on the items that are listed there. Are there any queries? I thought you might want to know that the Chief Executive and I, on behalf of the Trust, attended the service of prayer and reflection for the late Queen at Llandaff Cathedral. It was a very moving experience. It was very exceptionally well organised. It was organised with an inch of its life, but there was an awful lot of sitting around and waiting around. But it was an honour and a privilege to be there representing the Trust. And we have now left the official period of mourning, which is important. A number of events have had to be postponed because of the some of the charity events in particular have had to be postponed because of the period of mourning. And I said moaning then, didn't I? Mourning. I'm doing it again. But we hope that they'll be picked up again shortly. And just as a note for yourself, Lauren, Health Technology Wales, their adoption of evidence report is now completed.
Oh, great.
And it's been circulated, started to be circulated, and it is now appropriate. That I think we asked Peter and Query Sue to come and talk us through that. I think there are going to be some interesting lessons to be learned in terms of adopting evidence for us all. So if there aren't any, you've got there the report of my appraisal with the Minister. So I'll move on. I haven't had a chance to ask you yet, Carl, but are you going to talk to Steve's report if needed? Sure you will.
Yeah, I can do.
So item 3.20 is the Chief Exec's report. We only knew that Steve Ham was going to on sick leave yesterday, so Carl is very well as acting Chief Exec. Has quickly stepped into the breach, but you're not the author of this report.
No, all the hard work's done somewhere else, Chair. Yeah, I mean, I think Steve's report, as always, busy period, highlights, lots of good things. I guess there's a danger in just picking out a couple, but I will make mention of two things in this report particularly. I think the first is 2.1, the significant and value contribution that the blood service made amongst all those huge contributions in Wales and the UK. Again, that vaccination programme up and running, and special mention there. And the second point really, which probably is worth special mention, is 2.4, as you mentioned earlier, Chair, on the 19th of September, whilst the funeral was taking place, public services across Wales were still running, and particular note to all our staff, and again across the whole of public service in Wales for their contribution on that day, which made it a tricky day run as best as it possibly could. So there's lots of other good things in there as well, but I think those were 2 points of particular notes for the board.
Thanks, Carl. In relation to 2.4, unfortunately, Wales Online put out on Facebook that all routine services were being cancelled. So I spotted it, and I want to say particular thanks to our comms team. I reported it to the comms team, and they were very quick in getting hold of Wales Online and the health editor, who then put out because people were starting to write on social media that how upset they were that things were being cancelled. And our comms team reacted very quickly to that, contacted Wales Online, and a new article was issued with the arrangements by individual health board and trust, which was accurate then. Did you want to come in? Alana?
Yeah, just to say the editorial team did apologise, and as you say, responded really quickly.
They did.
So thank you to them.
Yeah, yes, I should say thank you to them as well,
Yeah.
but Non and her team were onto it straight away.
Yeah.
Thank you, Carl. Oh, sorry, Andrew, didn't see you there. Oh, and then
So it's just a quick comment. So 2.5, the new appointments, specialty doctors, associate specialists, doctor advocates. It sounds all very exciting, but I wonder whether there's an opportunity with Nikki coming into post for her to either meet the board or to be able to have some kind of, so we can learn more about that role. It sounds very interesting. We've only got a small paragraph about it. I just wondered whether is it a new appointment? It's not just a new person, it's a new post.
I wonder
right?
if Jazz might give us a little update, because
Yeah.
Nikki's well known to us in the trust. Jazz?
Thank you for that question, Andy. Absolutely, this is a new initiative in Wales, and this is about recognising the SAS doctors who have, so these are the grades of doctors who may be specialist associates who have history, in fact in Wales form a large proportion of our workforce, but are not career grades and historically have missed out on training, opportunities, leadership roles, etc. So there's been a huge focus on this particular group of medical staff to ensure that they are being represented. So this is a Wales initiative for us to have an SAS doctor advocate, and we're pleased to note that Velindre, in line with all the other health boards and trusts in Wales, has been able to appoint to this role. And the idea is really that we build a kind of community of support, well-being, but also development and leadership for this workforce group. So I'm sure Nikki will be delighted to come. Perhaps we should give her some chance to get herself embedded in the role. It's all fairly new, but it would be a good idea to invite her, and Sarah will know more as well. Thank you.
So I did see your hand up, Sarah, but can I invite you now, please?
Yeah, thank you, Chair. Yes, just to add to Jazz's point, so this is a very important role. So Nikki is a consultant within Velindre Cancer Centre in palliative medicine, chair of joint local negotiating committee. So we're very, very pleased that she's taken on these additional duties, if you like, to actually support the SAS doctors. I do think that we might learn more about the role in the future here, or perhaps through our committee structure, because this is starting now to build that level of support for medical staff, as Jazz says, which is going to be very, very important to support in this part of the workforce.
Thank you. Thank you. Any other observations on the SAS advocate? So we will invite Nikki. We'll give her a chance to get her head around what the role is going to entail and so on, and then invite her along. Vicky.
Thank you. Just a couple of questions on the IMTP part that's outlined in the Chief Exec's update, and the Appendix 1 where we've got the letter. I did raise this with Steve on email, but obviously he's unwell at the moment. So it was just really to ask, because I was concerned that it outlines that the cancer quality statement wasn't as strong as expected, and also just how we're going to monitor the accountability conditions that are set out in Annex 1. And I understand there had been an exec discussion on this, so just wondered how that would be brought back to QSP so that we can update the board.
Paul, thank you.
Yeah, if I kick off, I'm sure others will want to come in. In terms of the cancer quality statement, I think it's Jazz might want to comment as well, in terms of it's quite broad. And again, we're a specialist part of the overall system. So I'm not sure we're not strong in that area. I think some of the framework doesn't easily fit some of the services we provide. I think we do have a really strong understanding the framework, and our plans will deliver against the dimensions of it. But I think we're going around that with government, and particularly the policy divisions. The second part, the accountability, yeah, it's the first year of a strengthened set of arrangements whereby once our IMTP was approved, alongside that came a set of conditions which we also have to discharge, and that really brings it into the chair, directly then responsible to the minister for delivery. So in accordance with that, what we always do anyway is monitor our Q1, Q2, Q3, but we're now tracking the delivery against the accountability conditions. And on Monday, Laura and I took a paper to Exec Management Board, which set out the mechanism through which we will do that at an exec level, but also then bring it to QSP as an example for the assuring committee to demonstrate to the board and to the chair, because she'll be reporting to the minister that we are doing what we said we would do. So, and the first time the board will receive that, Vicky, will be in November.
Okay, that's lovely. Thank you.
The minister is especially interested in cancer performance at the moment, and she discussed that with the chairs at the beginning of this week. The chairs met with the minister, and there's to be a summit early next month looking at exactly the issues that you just described, Carl. So yeah, we'll keep Vicky informed as chair of QSP, so that you know where that work is going. Was that, we answered both your questions? Yeah. Martin, yes, please.
Can I just follow up on that, because I think that's really important. I mean, we shouldn't get away from the fact that the letter from Judith Badger is very positive in terms of accepting the IMTP, but that paragraph is raises some issues. And I hear you say the QSP is going to be kept updated, but I think the board needs to be kept updated as well. So I think that the responses to the issues raised in Annex 1 are, we need to make sure that we as the board keep on top of those.
Yes, Lauren, thank you.
So yeah, just to expand a bit further on the process then. So in 2.3, as it notes, there's a paper which went to Executive Management Board on Monday this week, which is on the agenda for Strategic Development Committee on the 13th, because as well as the accountability conditions being an important aspect to report on for 22-23, they also need to be in view of the Strategic Development Committee in endorsing this year's IMTP plan, because by definition they need to be reflected in a different way in next year's plan. So so we thought it's appropriate to bring that overall approach to Strategic Development Committee, and then the quarterly reporting will come to the Trust Board in November. But as Vicky pointed out, what I should have added to that sentence is following QSP in November. So that'll be the quarterly reporting then to board going forwards across all the conditions.
That's helpful, thank you.
So everybody happy with that? So we note the content of Steve's report, and of course we wish Steve well, and hope he recovers very soon. So we now come to section 4 of the agenda, and 4.1.0 is the cover paper, which starts off the suite of papers of delivering excellence and performance. I can see Kath on screen.
Yep.
Kath, are you introducing this paper?
I am going to introduce the paper. So I'm going to cover off both the Cancer Centre and the Blood Service, and then pass on to Sarah Morley to cover off the trust-wide workforce performances as well. So I'm going to start off with the Cancer Centre report, following the order of the cover paper. And what I'm also going to include in my update, there's a clear summary of the performance there for July, but I'm also just going to touch upon what we've experienced in the last couple of months as well, to give you an understanding of the trajectory of where things are heading. So you can see again in July that we've been considerably challenged in terms of our performance, and we're continuing to make the most of the capacity that we have to respond to the variation in demand that's coming through from the health boards. And we have been scrutinising and managing that very closely, both operationally within the Cancer Centre and also with the executive team, And through the period of the summer, we were having weekly meetings with the Cancer Centre to ensure that we were all doing everything we could cohesively together as a team to maximise the capacity that we were able to offer, both in terms of physical space and equipment, and also workforce. Considerable developments have been made over that period of time. So although our performance was really not where we would have liked it to have been in July, I'm glad to be able to inform you that during August and now on to September, we are seeing considerable improvements in that performance. So I'm going to give you an update on the two main service areas briefly, and then I'll just see if there's any questions that anybody's got on any of the details on that. So in terms of radiotherapy and SACT, we know that one of the major impacts on our performance was the plan that we had for some of our recovery capacity to be through the Rutherford Cancer Centre, and the sad situation that centre found itself in terms of not able to support our services. So through July then and into August, we were working through some of the impact of that. But we were also experiencing some variations in the referral pathways from the health boards, which meant that we were getting variations between tumour sites as well. And that we know that for radiotherapy, the configuration of our machines mean that it's not quite as easy to utilise different machines at different times. So the good news on the radiotherapy performance is that again, it is continuing to improve from that July figure. And we have seen the increases in staffing that we were anticipating in September. And it said in the cover paper from QSP that we were anticipating all of them in September, but actually there's some more staff to come through in October. And we're not anticipating that situation is going to change at the moment. We're continuing to have a challenge with the medical physics workforce, and the team are working through how that medical physics workforce can be best utilised. And we're already seeing some, improvements in capacity as a result of that work that will continue now through until the end of the year. And then the other piece to add to that is that we're still working very closely with the medical workforce to look at how we can reduce any variations in the pathway, to just make sure that we're able to capitalise on those small incremental changes, as well as some of the bigger changes that we're making. So that's covering off radiotherapy. Oh, actually, sorry, one other point to add is that next week we will be starting the decommissioning of LA6, one of our linear accelerators, and that will be the bunker that's in will then be prepared through the autumn for the new machine to be delivered, and for the commissioning of that new machine to commence between January and March next year. So in terms of chemotherapy, in terms of SACT, again, the figure really not where we anticipated for it to be in July. But again, the good news that is starting to return, and the trajectory is upwards, with us exceeding 77% in August, and we're expecting that to improve slightly again in September. We've managed to increase capacity for these patients by taking an approach of increasing the capacity that we have for delivering interventions with patients and support for patients that doesn't require it to happen in the SACT provision area. And so we're really grateful for the support that we've had through the ambulatory care unit and throughout patients in terms of some service configurations that have enabled them to see some patients in those settings rather than in the SACT units. Again, our staffing recruitment is underway, and we've seen a number of new starters, which continues to strengthen our staffing position. And then a really comprehensive piece of work has been undertaken that's really just looking at our staffing and our skill mix in SACT provision to identify where we can make changes to not only add to the workforce, but also to increase the efficiency of the workforce that's operating in that area, and how we make the best use of everybody's skills. So I'm going to stop there, having covered off radiotherapy and SACT as a headline figure, to see if anybody's got any questions. And then if anybody's got any questions on any of the other performance within the Cancer Centre.
Thanks. Can I can see Vicky's hand up, but I've got one or two things the first paragraph on page 5, Kath, where it says all these patients would have been clinically prioritised by the clinical teams. What I'm looking for at board level is to be assured that they were because what that says is we've got a policy which is that patients should be clinically prioritised. Yes, I get that. Were they? So so that just would have been made me think I want assurance that they were.
And we are in the sort of end stages of the completion of an audit of the clinical prioritisation that's been undertaken. So we will feed the that through the normal channels over the next sort of cycle of the board. But I'd be more than happy to provide you with some details on that when outside the meeting process as well, Chair.
Look, if it had said all these patients were clinically prioritised, yes, then I'd be content. It said would have been, so I can't take assurance from that. Do you see
what you mean about the choice of language?
Yeah.
Yeah. So
they were.
Yes, they were.
So, well, thank you for that. And I've got another query, which is why has repatriation to Prince Charles Hospital taken so long and it's still not completed? You know, we've been hearing about, you know, we're going to get patients back to PCH for several board meetings now. And I'm just wondering, what is it that's taken that it's so long for that to happen? And so for members of the public and for everybody else, this is during COVID, our patients that received SACT therapy and some outpatient services at Prince Charles were brought back to Velindre Cancer Centre to be looked after because of the COVID issues. But it does seem to me to have taken an extraordinarily long time to get that repatriated.
Chair, I'll start with the good news, which is that the week commencing the 10th of October, we will be returning to that full service up at Prince Charles. The reason that we haven't, and the challenge that we've had, is that when we were short-staffed, then it gave us a greater overall capacity to deliver in the cancer centre because we had more flexibility, whereas we wouldn't have been able to see as many patients. So the choice to change the date of moving back to Prince Charles was a really challenging one that we had to make. And it was around making sure that we used the staff that we had in a way that enabled us to create the most capacity that we could to see our patients in a timely way. So it was. I mean by that
the staff that normally would have been based in Prince Charles came down to the cancer centre.
That's been the position, obviously, during the pandemic. The plan is for them to return, but in the cancer centre, by operating in the cancer centre, those members of staff could see overall that we could maximise the use of those staff to see more patients than if we'd sent just a small cohort of them up to Prince Charles.
Nick, you wanted to come in on that point?
Yes, Chair. So the SACT nursing team are one team that rotate across all the sites. So they're not actually allocated to certain parts of the trust. So as Kath has described, that is the case, but it's just they do operate as one team. So there isn't a Prince Charles team necessarily because they are all Velindre staff that work across. So we have been running Prince Charles for some time, but just not up to full chair capacity, which is now happening in the next couple of weeks.
So my query is, why is it taking so long? Because it has taken an extraordinarily long time.
It's aligned with the increasing of nursing capacity. So we have recruited additional nurses within the SAC team. It is a lead-in time for training and competency to be assured. So that is why it's taken us so long to make sure we get the sufficient staff to be able to run the optimal number of chairs and available chairs at Prince Charles. And that will be concluded within the next 2 weeks, which is why then we're able to open the additional chairs.
Well, thanks both. And then finally from me, outpatients. Maybe my colleague on my left here, Stephen, might have raised this. So that's on the top of page 6. And what it says is we are reviewing a number of new outpatient KPIs as part of the new PMF development that will enable a wider view of the service delivery in this area. So the concern that some of us have had for some time is the length of patient waits in outpatients. This has been well rehearsed at this board. I'm a little bit concerned that drafting new KPIs, this sometimes can be interpreted as we can't meet our targets, so let's have different targets. And so I just want to be and we heard this with ambulance trust, didn't we, when some of the targets for 999 calls weren't being met. And we understand all the difficulties. I'm not criticising the ambulance service, I'm using it as an example. And when I thought more appropriate targets were introduced, the public perception was, oh, this is because you couldn't meet the original targets, so you're just making new targets now. So can I be assured that that in developing new KPIs, we're not developing targets to make it look better than it is?
Absolutely, Chair.
Carl was going to come in. Do you want to answer? Kath, sorry.
No, sorry. I mean, I'm sorry. I couldn't actually see who's on your right and who you're looking at, Chair. So I mean, I'm sorry. Let Carl come in first. I can follow up if you require.
Having worked in Welsh Government and also in the ambulance service, I got some experience in this sort of understanding. I mean, I think what we've got right now are a range of sort of inputs, throughputs. What we're all trying to understand is quality of care, safety care, and outcomes. I think for the NHS more broadly, not just our organisation, because we're going to mix a bit of everything. So if you recall, what we're first of all trying to do is make the best use of what we've got, and then secondly, working with Nick and the service and Jazz and others, is really measure what matters most in terms of the outcome of that care, the quality of the care, the experience and the safety of it. So you'll still see quite a number of these measures there because they're important. So time is an important function of experience and care for some things which are time bound. And if I give you the example in the ambulance service, then whereby you get an ambulance there in 8 minutes, but actually we didn't then track the outcome. And similarly, within an A&E department, you get seen within 4 hours, but actually you get your scan, but the scan wasn't read for 4 days. So we just need to understand where the big points of value are added and measure them appropriately. So we will absolutely ensure that the new measures are patient and donor focused and actually measure the difference we're making in the quality care we're providing. And we're not changing the targets for changing the targets' sake, because many of those measures still will be extant in the new framework. And again, Jazz and Nick and other colleagues will want to comment, I'm sure.
Thanks, Carl. Does it? I know, Stephen, you wanted to. I know, Vicky, I haven't forgotten you at all. But Stephen, I think you wanted to say something in relation to this item. The point I've just raised.
Yeah, it was actually tangential to it regarding outpatients. Sorry, my voice is going very dry in this atmosphere. It's more a question for Kath, really, or a comment for Kath. I met with Kath 7 weeks ago, and one of the areas we discussed, Kath, was around the clinic booking rules, which, as we all understand, in part drives the flow of patients through clinic and how quickly they are or aren't seen. And we had a very useful conversation. I'm just wondering if you just wanted to take the opportunity just to update the board very quickly on where we are with reviewing booking rules, particularly in the light of replacing CANISC and the opportunity that presents. So that's a tangential question, Chair. So perhaps we haven't finished with your question yet.
No, I've had my question answered, so we could deal with that, and then I'll go to Vicky. Kath.
Thanks. So, Steve, just to add further to Carl's response, actually, and Stephen, again, it was the basis of the conversation that we had. I think we need to remember that the data on this metric is actually a manual count, because our current system configuration doesn't allow us to do it automatically. So we will be looking at how we can capture this metric in future. But as I said, we recognise that there's more of a story to tell around what happens in outpatients. The outpatients is a department. There's an awful lot of different activities that happen there. And what we wanted to do is to make sure that we tell a comprehensive story around both the patient experience and our compliance with the processes that we use for making sure that our patient care is where we want it to be. So look forward to having some further discussions. And when we do propose new metrics, there'll be a clear opportunity for us to give those a really good airing and some good discussions before they become a formal part of anything that we do. So just to give you that assurance. In terms of what we're doing with the clinic booking rules, one of the pieces of work that has fallen through the out of the implementation of the replacement for CANISC, which I'm sure we'll talk about later on the risk paper, is that it's meant that we've had to have standardized templates for putting into the new system that have really challenged us to how are we actually setting up and operating each outpatient clinic, because there are different requirements for, you know, for different ones. So really sort of starting to standardize that and looking at which members of staff do the tasks for which particular clinics. So not only through the DHCR implementation have we had to take a good long look at that, which will have impacts on beneficial impacts on patient experience, but also what it's done is it's created an opportunity for us to continue to look at that and undertake service improvement activity around those clinic systems and clinic bookings and all the functions around that. So some changes initially at the start now with DHCR and the setup, but more changes to come as part of our continuous improvement as we work forward.
But Jazz, you wanted to come in on that point?
Yes, thank you, Chair. I think what I just wanted to remind us about is that this, I guess, the environment, you know, pressurized environment in terms of the activity that we're trying to grapple with. And I think one of the challenges that Kath has been very diplomatic about, I think that the medical staff are quite tricky about the booking of patients in their clinics, because we don't want patients to wait to see us. And that's the bottom line. We ideally don't have a wait if we can, but that means that we are guilty of overbooking our clinics. And we've got to get a balance, which means that we can accommodate the patients in a timely way. And this does require a different way of thinking and working with our admin team. But fundamentally, we are, patient-centered in that approach. I guess part of this sort of what are we monitoring is something that we need to do as a collective. We need to understand what are the priorities in that, what are the issues that are going to lead to better outcomes, what are the issues that patients are most concerned about, and work as a collective to develop something that is meaningful and adds value. Not easier said than done, given where we are, but we're absolutely committed to do that. Thank you.
Thank you, Jazz. Finally, no, well, not finally, at last, I should say, at last.
Okay, Kath, just a question for clarity, I think, for the board. On the bottom of page 4, in terms of radical radiotherapy, and we had this discussion in QSP, and I know you were unable to be there that day, but nationally there's concern about the potential harm for cancer patients. And in the treatment, we're outlining that 55 didn't begin treatment within the 28-day target. We then break it down in terms of breast cancer patients, of which there were 38 of the 55 breaches, but we don't have a narrative that explains the rest of those breaches and when they were treated by, and it's an issue that's come up in QSP a couple of times, and it would be helpful to have clarity here, but in future narrative as well.
Thank you. So I don't have the detail on those additional breaches. I'm sorry, but I will make sure that the format that we report in shows those breaches. The one message that actually you've prompted me to say, and I think this is a question for around how we present our data, is the fact that we're talking about our breaches, and in the presentation we put how many by how many days. But what we're clearly not showing is that although our performance hasn't been where we would like it to be, what we have seen in more recent months is a shortening of the tail of the timescale within which patients are seen after that deadline. So that has been an improving picture. Which again, we're not doing our best in explaining to provide the board, at least with that level of assurance that things are improving. So I'll take your comments, and I'll make sure that we improve the way in which we're articulating that in our summary. Thanks, Vicky.
Thank you. Thank you, Kath. And then before we move on to radiotherapy, I just want to make one observation, and it's in relation to sepsis, and to congratulate the team on their performance in reacting to potential sepsis in patients. It's not that long ago, I can't remember how long ago, Nikki, but we were having, patients weren't assessed in an appropriate and timely manner. And there's 14 patients, which was a lot for us, because it was just about 2 or 3 patients I was thinking about a year ago, 14 patients all met the criteria for the administration of sepsis bundle and all received all elements of the bundle within an hour. And, you know, we do note when performance doesn't meet our expectations. I think it's important to note when performance does. So we could note that and pass our congratulations on to the team. Nikki, please. Carl?
Just before, are there any more questions on the cancer? I just want to make a quick point before we move on. It was just something Kath mentioned was really important, and in terms of the overall clinical model. Is it on? Sorry. And obviously, a focus of the TCS committee has been how we implement that model post-COVID. So how do we get back into outreach? Because obviously everything else, our model is more at home, more locally where appropriate, and only travel for specialist care. So I think, you know, again, joining the things together, the points that Kath has shared with the board this morning show a couple of things. First of all, local access is really important, and people are getting more of that, and that will continue. But also getting back to where we were March 2020 in terms of our outreach offer and then pushing on a bit further. So that has been a real focus of our conversations in that subcommittee. I think Kath has really illustrated this morning that work has been planned and that has traction, and hopefully if we can stay away from COVID for a little while and get the workforce back in, we should really see an acceleration. So it's just making sure that the board is cited on the different conversations at various committees, because it has been a focus, Stephen, has it, on making sure that when we open the new hospital, it's got sufficient capacity to manage what we expect to be in there on day one. So I just thought I'd sort of mention that as an eye to the future.
So that's something we've got to keep a careful eye on now as we go through the process of commissioning, getting the new hospital ready. Thanks, Carl. So Kath, I think we are ready to move on to radiotherapy.
Yeah, sorry,
Welsh
blood service. I thought you meant that. So could I just add to the point that Carl made, just to say that there is a focused piece of work that we're doing at the moment, which is really looking at our sort of post-COVID return to outreach and aligning it with the trajectory for the aspirations within the TCS case. So that work is being re-examined and replanned at the moment. So looking forward to continuing to take that forward. So just to WBS, again, June, July, a tale of considerable difficulty for the service, but I'm really proud that we managed to keep the service running through hard work in collaboration with the health boards, where their confidence in working with us has enabled us to really carefully manage the stock throughout that period, when we had some of the lower stock levels that we've had for some considerable time. And in parallel with that, the other UK blood services were also experiencing difficulties. So our collaborative working with them and with the health boards managed to get us through. We had a blue alert running through that period. That blue alert basically means please be cautious, think about what you're doing, be mindful of the fact that the stock levels are tight. So as well as that operational management of the stocks with the health boards, clearly we have the initiatives around appropriate utilisation of blood through the blood health plan and our work with the health boards on appropriate use, as well as managing demand. I'm really glad to say that that alert level was removed in August. There was considerable work and support from the staff in terms of additional clinic capacity and additional clinics, and also additional capacity within the clinics that we were holding. So thanks to all of our staff on that. And our stocks are continuing to build now through August and September, and we're finding ourselves in a really solid position at the moment. We're not sitting back on our and taking off the gas on that, because we are recognizing that we could all potentially be in for quite a difficult winter. So we're continuing to look at that plan now for the forthcoming months with the health boards, and to run some exercises to look at the impact of potential catastrophic blood shortage. And we're running an exercise with the health boards now over the next few weeks to just do that scenario planning that we hope will only ever be on a piece of paper. The efficiency of the service is still going to vary as we're really starting to return our model. We know that we had to pull back from some communities during the pandemic, and we're returning to those as and when we can. We've got some changes to venues and some changes to the ratios of what we're collecting and where, but we're really starting to work out now what this new model for the future looks like, based on where people want to donate and where people are living and working, because we know there have been some considerable changes in both of those. The other element that I wanted to highlight then was the bone marrow donor volunteers. We know that we like to recruit young people between the ages of 17 and 30 primarily, although there's not a cut-off there clearly, to be volunteers on the Bosch Bone Marrow Donor Registry. And we know that we've been constrained in the last couple of years in terms of our ability to go to schools and colleges through the pandemic. We've got a massive drive on now through September, October, as we get return to schools and to universities, to make sure that we're out there recruiting not only blood donors, but also people that aren't going to be blood donors, using the swab methodology to get that DNA sequencing to enable us to put people on the bone marrow register without having to be a blood donor as well. So that's being managed on a weekly basis, with our targets being set and performance being carefully reviewed by Alan personally on a week-to-week basis at the moment as we go through the autumn. And that activity at the moment is then going to be supplemented by some fuller and more strategic planning for the recruitment to the registry, and that work's going on through the autumn, and we'll bring that to you when that work is ready. Those are the two things I wanted to highlight for the blood service. Again, happy to take any questions anyone's got on any other aspects of performance.
So I've got Vicky, Stephen, and then me. Vicky first this time.
Thank you. Kath, just applaud Welsh Blood Services in terms of the statutory and mandatory compliance for training, which is at 92.18. But which is fantastic, but actually really concerned about the sickness absence, and how they've done that with that sickness absence is quite surprising. But you know, their sickness is 8.49, so I guess the issues are really how do we understand the reasons behind that, and is that going to resolve fairly quickly in order to sustain the service?
Thank you. Like any headline figure, there's a myriad of factors underneath that are contributing to that, and we have seen the absence in some pockets, and it's not widespread across the organisation. Alan and the senior leadership team are working with workforce colleagues to make sure that we're effectively managing sickness absence and providing support on an individual staff basis. There's some work pressures and non-work related stress that are contributing to some of that, but there's a very carefully managed action plan that's underway with workforce colleagues to address all of those factors.
Vicky, Stephen, please.
Jane, hi Kath. I may have brought this up at QSP, or I may even have said it last time at this board, but we had a conversation earlier about targets, and of course when we to exceed the target is set it very low. So I'm coming back to page 8 of the report itself, the PMF report, and we've got then under the broad category of first class donor experience, donor satisfaction, and the target is set at 71%, which to me sounds extremely low. We're achieving 95, 96%.
Yeah.
But I'm wondering why that just seems an awfully low target to me. The question I think last time around was who sets these targets, and if they're set nationally, that's fine. Agreed that we are happy with the 71% level of donor satisfaction, and if so, would we want to review that? I think I've asked this somewhere else.
Yeah.
Possibly last time.
Yeah.
So I'll just make a general statement about this we're going through, and Nick and Kath will comment on the particular. So absolutely, we're, as part of the PMF refresh, we're also refreshing all of our targets. So there's a series of different types of targets, and one are their national standards. So there's a number or a standard to be achieved, and there's some which are from 2. We're going to get from 0 to 100 in a period of time. So absolutely, Stephen, as part of that process, we will be refreshing, looking for either national targets, professional standards, benchmarking with organisations to really start to understand against our level of performance where we are now, where we aspire to be. And they've got to be realistic and achievable as well. So I think there's all those things. So that's an example of one of those where we've clearly exceeded that for a number of years. So that will be one which will be refreshed in accordance with where we think we need to get to. So that was the general process we're going through. I'll hand across to Nick and to Kath for.
Yeah, it's just a little bit more detail. So yes, you're absolutely right. It's something I've raised since I've been in the trust. It is historical. It's not a national standard, and the discussions I've had with Welsh Blood is we would be looking at 95% for the new scorecard.
So if that's I've got two queries I wanted to to raise in this introductory paper. We've got issues on concerns and sickness in the WBS, and that isn't there in the cancer centre reporting. And I just wondered if we could have some kind of consistency in terms of what you're going to put into the cover paper. Clearly, if there was a serious issue to do with a very serious issue to do with sickness, or a very serious issue to do with certain issues, you might want to put them there. But complaints are reported in the introductory narrative and concerns for WBS, but not for it's in the body of it's later on, but it's not in this cover paper. So I think there should be some kind of, if you could have a think about consistency of reporting. And then I'm not sure if I'm worrying unnecessarily. I need to get my mouse onto it right. But you've got whole blood collection productivity, and you're looking carefully at donor non-attendance, which that's fine. If efficiency can be improved by overbooking of appointments or controlled walk-ins at carefully selected clinics, in addition to the 6-chair mobile units being scheduled to return, and a review of individual venue capacity continues. Kath, you know what I'm concerned about is that we do try our very best to enable every member of the Welsh population to donate blood if that is their wish. And looking for larger venues which are very efficient and we don't need to discuss that now, but I'm keeping a very careful eye on that. That if we go to the large venues, that can sometimes, which is very efficient, it can sometimes deprive individuals of the opportunity to donate blood, and that also takes away from placemaking, which is also important in some of the very small communities. And then I've got a sort of a plea from a donor experience, and I've just hands up. It's a member of my family. The last 5 times they've donated whole blood. First time was Ystrad, the second time was Port Talbot, the third time was Llandarcy, the 4th time was Merthyr Tydfil, and the 5th time was back in Ystrad. He has to, and I live in quite a reasonably large town, but people are having to travel all over South Wales in order to help us out in donating blood. And I'm just wondering, that is not efficient in terms of energy consumption, that traveling all over those, going to places you don't know, so you have to kind of, where is it, and you're relying on postcodes and things, because in order to if you ring up and you want an appointment, you're told the only appointments we've got are in X, Y, and Z, which is often over 20 miles from home.
Absolutely, Chair, and the comments you've just made and the discussions that we've had, are at the forefront of our minds and part of the planning process. So for us in planning where we're going to go and make our collections, there's a number of factors that we have to consider in terms of the sizes of the venues, but also the mix that we've got of the different blood groups, which you remember, which is why we moved to more appointments during the pandemic, because that gave us more ability to be able to make sure that we had sufficient stock of each blood group. But the planning that the team are now doing to really establish our new sort of rhythm in a post-COVID era still absolutely has at the heart of it reaching out to every community that we can. The question will be the frequency with which we're able to do that. And also we've seen some considerable changes in the venue availability as well. So we are managing all of that, all of those factors. The principle of going out to communities is still one that is absolutely the core of our planning. It said a lot of factors that we're having to balance.
Thanks, Kath. I think the thing that worries me is if when you need donors, what can be very off-putting is if you've got to travel 20 odd miles to get to the clinic, and that could mean you've got to take 2 or 3 hours off work. Whereas if it was a bit more local, you've only, it's just about an hour and you've in, out, rested, had your drink, and you're back in work. So if that could be looked at, and we can stop people having to travel all over a huge region in excess of 20 miles in order to donate blood to us.
Absolutely, thanks.
And it could be that my family member is the only person that's experienced this. So, so that's the first point to check. Is this atypical, or is it, does that happen frequently? I haven't got any other points to raise in relation to Welsh blood. Anybody else got any points to raise? So shall we go to Workforce and OD next, please, Sarah?
Thank you, Chair. Just to build on what colleagues have already said, we've got our 3 headline key performance indicators, obviously, in terms of the trust-wide performance. So just taking personal appraisal development review, PADR first, you can see that as an organisation, we're tracking here just below 70%. In terms of figures beyond that for August, we've actually gone slightly over 70%, which is not represented in this report. What we know is that that's not where it should be in terms of the target, but we also know that there are myriads of other conversations going on. And what I've been talking to the team about is how we start to, now we're got through the COVID situation, if you like, try to better understand how we add more value. And this is a conversation we'll have had a long time ago as well, but rather than just rely on this annual appraisal, because clearly the point of it and the added value is those value added conversations and knowing people as individuals. And that's really what we need to put in place there. So there will be conversations happening about how we better do that. But also, of course, recognising that, again, headline figures, you can see some of the breakdown underneath in the report, but there are pockets where we are above target, and there are other areas that we need to continue to focus on. Then if I can just move to statutory mandatory training compliance. So this is compliance against the 10 topics that are contained within the level 1 core statutory training framework, which we're asked to report on as a tier 1 target for the organisation. So you can see here we're actually above target as the organisation as a whole, which is excellent. And actually Welsh blood, again, as Vicky rightly pointed out, extremely good performance there, and VCC doing very, very well as well. So, just commend colleagues really on the efforts that they have put into getting us to that level and maintaining it over quite a number of months, given all of the other pressures which we've already discussed today. And we also know, of course, there's particular emphasis on different areas of level 2 training, which tends to be then the more specialist training, which fewer colleagues need to do, but which is even more important in a way, isn't it, to delivering safe services and keeping colleagues safe.
But Sarah, I just want to endorse that last comment that you made. This is astonishingly good compliance with level 1 statutory and mandatory in the context which you described in your comments just then. That's something to take real pride in.
Absolutely, and tracks us above where other colleagues are in NHS Wales, really. So again, just commend colleagues for that. In terms of sickness absence, of course, this is a perennial issue. And of course, as an organisation, what we've seen is our numbers have been tracking upwards through the pandemic and then continuing beyond it. And we know the tail, particularly in relation to stress, anxiety, depression, which is about 1/3 of our overall absence levels, is particularly concerning. For the year to the 13th of September, which is the most up-to-date information I have, the level as a whole organisation was 6.36%, so slightly better,
down.
but we can't take too much comfort in that with just one figure. What we know, and Kath has rightly said this, is that there are a myriad of different varieties of absence levels that sit within teams below that headline figure, and colleagues are working very, very hard with hotspots So we've got our senior business partners within each of the operational divisions, working closely with senior leadership team, senior management team, and then managers to look through all of their absence and actually manage on a case-by-case basis where we need to, trying to help people come back to work appropriately, provide them with opportunities to do that in a number of different ways, and really taking that person-centred approach. That's at the heart now of our managing attendance of work policy, which is an always policy. It's not a punitive, structured approach. It's much more around what is the person in front of me needing here, because there may well be, and there will be, factors outside of our control in the workplace, but we can still support people. And what I would also say to that is a number of things that have happened in the last couple of months. So we have now got our staff psychologist in the post, who is looking at supporting the workforce team in particular, taking referrals. So when we are presented through that case-by-case work with people that we feel they need something beyond counselling and need other psychological interventions, we now have somebody within the organisation who can do that. That is looking at staff as an area of focus as opposed to patients and other service delivery elements, which is a fantastic thing for us to have. We also have just completed an advisory audit. So the audit team have just completed this, which is just really reassuring us that the interventions we've already got in place around wellbeing are what they need to be. They are presented in a timely way. They are aligned with what goes on in the rest of NHS Wales. What we know we don't do yet, as well as we should do, is measure the impact of certain interventions. So how much difference are different things actually making in terms of people's well-being? So we'll now be doing a piece of work to further develop that through the Healthy and Engaged Steering Group, which we have within the organisation. Healthy and Engaged Steering Group. So I'll stop there, Chair, but happy to take any questions.
Thank you. I can see Vicky and Stephen with hands up. So Vicky, please first.
Thank you, Sarah. I mean, I think just put on the point of sickness but absence as well. I think across QSP, we know that obviously workforce is a massive triangulated issue that impacts on a range of issues. But just wondering whether we can change over the next few months the high level figures so that it includes absence. Because in the detailed paper and tables, we've got COVID specific absence, non-COVID specific absence, as well as the sickness. That contributes to a higher figure than 6 point, whatever it is. Sorry, I'm not looking at the figure, 6.42. So it's actually how we understand the enormity of the absence and then the impact on the operational as well as clinical services, which is really important as QSP and the board consider the impact.
Yeah, if I may check. So I think what you're suggesting there is that people who are off work for other reasons to actually be included in an overall impact figure. I think that's what you're describing. Okay, we'll have a look at that.
Okay, thank you, Stephen.
Thank you, Chair. When we've got a theme developing, we have targets and target setting. So I'm just looking at the sickness absence figures here, Sarah, and I'm going to wind back to conversations I think we had back in 2018 about the actual target sickness absence itself. And I'm trying to remember those conversations. At the moment, it's set at 3.42%. which sounds like it's the product of some highly technical process, which is resulting in this figure. My recollection though is I think it's been imposed on us, and it's actually relatively an arbitrary figure based on historical sickness levels and trying to drive those down even further. So we obviously had the pandemic, and it was always difficult to achieve this. And if I'm honest, I've always thought this is unrealistically low because we wouldn't want our staff coming in if they're sick, both for their own benefit and for the benefit of patients. So I've never really understood why it was ever set at this low level. But it seems to me now that this really needs to be recalibrated. And I'm wondering, has there been any discussion nationally in the post-COVID environment, certainly for the next few years, what is a realistic sickness absence level target? Because we're so far off target, we don't even have a conversation about how far adrift we are, because we all understand why we've got high sickness, and it's such a huge gap from the target. Whereas if the target were reevaluated and there was something realistic put in place, we could then have a meaningful conversation about the target's meaningful, we are slightly above it, because rather than not even having the conversation when we're 3 or 4 percentage points adrift, and I come back to it, that's because I believe 3.42% is completely unrealistically low for a public sector body delivering care to a local community.
Should I
Sarah?
come back in? So I bit my lip a little bit when you said that then, Stephen, because I think just to also be aware, some colleagues here wouldn't have been in some of those earlier discussions. So it's a really good question around the target. So back in, if my memory serves me correctly, I was in another organisation then, but back in around 2011, so that's actually 11 years ago now, the decision was made in Welsh Government that sickness absence should be reduced by 1%. So every organisation had a 1% reduction in their current level of sickness applied as a target. So that was how technical it was at that point.
So
Well, that's how you got down to 3.
Sorry, just to be more specific though, I think it's 1 percentage point.
So I'm sorry, Steve, you're
Which is a
absolutely
big
right.
difference.
1 percentage point.
It wasn't 1%
Not 1%.
off 4.5%, it was 1% off
4.54% at the time. Yeah. So you're quite right. That's a very important point, isn't it? So that's how technical it was at the time. When I came in post here, obviously the target was here then 3.54%. I had a number of conversations with the government, and back then it was, yes, we need to look at it. That was ever actually done. To answer your question specifically, there have been no subsequent conversations about looking at that, and certainly none since the pandemic. So that's currently where we are. I've made a note though, actually. I need to go back to government and say, look, are we going to now redo this and have another look at it in the context you've just described, Stephen, which is absolutely right. So that's why, in a way, we've moved away a little bit from continuing to say, well, how far away from the target are we, rather than having a more value-added conversation about absence, especially in light of the managing attendance at work policy, as I say, which is taking us away from that more punitive approach, which we may have seen 10 years or more ago via policies and the way they were driving us. So thank you, Stephen. I've made a note to actually follow that up with government.
Thank you, Stephen. Thank you, Sarah, for that reply. So, oh, Martin, I didn't see you there.
And just to add to that general point, I think there's a different conversation about staff absence and what is sickness. You know, back in the days, struggling to work as a trooper was sort of applauded, and people bringing bugs into the workplace was almost encouraged by this. You need to be in work. I think with the world is a different place now, isn't it? So that's one of the reflections is, if you have symptoms of this, you don't come into work, and that's the world has changed. So as a result, sickness levels, I guess, are actually going up. Not just COVID, but just generally people are being more cautious, I think.
Yeah.
I think I don't know what the evidence base for that is. It makes common sense, but I wouldn't know what's your response to that, Sarah?
Yeah, it's certainly in terms of I can't point you to a specific piece of evidence, but in terms of the literature, what the literature is saying is that we're actually seeing an increase in presenteeism. So what you're suggesting there, Martin, is people will be more likely now to be off rather than struggling to work. Yeah. But actually what we're seeing is both. More people are off, and we're also, the literature is saying, seeing more people come into work who perhaps are feeling the pressure of needing to be in work. So we've almost got that dual pressure in the system, which does mean that presenteeism could also be an issue for us. But that, of course, is much, much harder to measure and understand. And that's why we need to continue to, I mean, the number of times I've said to people over the last few weeks, you need to be kind to yourself first. Yeah. Because actually, if you're not doing that and not looking after yourself, then you can't be working effectively and helping us look after patients, donors, and so on.
So if I can have the last point from yourself.
Yeah, I think it's just to build on that, because I think other health boards across Wales will be facing similar issues. And it would be quite helpful for us to understand the context of our sickness and absence in the context of other health boards as well, just so that we feel where we are as an organisation.
Yeah, we can do. Absolutely. So we do benchmark with other organisations, and there is a national dashboard, which historically for us, we haven't made a lot of use of internally, because it's included Velindre as a legal entity, which includes shared services and at the time other hosted organisations, which of course we know in terms of staff numbers hugely skews our performance. So the comparison hasn't really been valid or useful. We are now in a place where over the next few months, we're going to be extracting Velindre that we talk about here in terms of these numbers and separating it from NWSSP predominantly, isn't it? It's the staff group we're talking about. That's then going to give us a much more timely ability to benchmark. We do it in other ways, but in terms of that dashboard, that then adds a lot of value to the conversations, I think.
Thank you. So we were asked to note the contents of the paper, but I think the minutes should show that there's been a thorough discussion.
Yes,
With several challenges raised and responded to.
Yeah.
As well as noting the paper. And thanks to colleagues, it's a long and detailed paper. So this is the last we were until this paper more or less on time, and now we've slipped behind.
Well, I was suggesting we don't have a break. We're stopping for lunch at 12. Probably it's only half an hour. Then we'll be on track.
Okay.
It would have gone 2 hours.
It's out of the world.
Says off camera.
Should we have 5 minutes now? 5 minutes now, and then we'll come back at 4.2. I do need a wee.
Okay.
So, colleagues, if we can, it's 26 minutes past. I will be starting at 1 minute. What will I be starting at?
31.
11:31. I'll be starting back, and we need to make sure we complete the agenda. Right. Okay, 5 minutes.
And that is a green position for the year to date and forecast balance for the year end. Capital is also green in that our costs that we're forecasting to spend on capital are within the current funding envelope from Welsh Government. And our public sector payment performance is also green and it's meeting the 95% target. So I'll just highlight the key assumptions around our revenue position and therefore also the associated risks. So the first one is in terms of our COVID response costs, which are running around 1.1 million for the year forecast. The assumption is that Welsh Government will continue to fund those, and therefore obviously that would be a risk if they didn't, and we would have to find funding ourselves to cover some or part of those. The next one is the exceptional national cost pressures, so energy. So the cost of our energy is now running at a forecast £3 million for the trust from our baseline of 1.2 million. Again, the assumption is across Wales, the NHS has had assurance from Welsh Government that they are covering that risk. But like all risks, there is other risks that Welsh Government are handling at the moment around the pay award, particularly, which hasn't yet been fully settled. So I'm just flagging there could be some element of that cost that Welsh Government may be looking to the service to cover. But at the moment, the assumption is they'll cover it all. And then the savings is the other area then to highlight where the assumption is that we will deliver on all our savings plans and targets in order to achieve the balanced revenue position. And the final one in terms of our assumptions and risks are around the COVID recovery capacity and costs. So we have invested £3.9 million in COVID capacity to deal with the COVID backlog. And we've started investing in that last financial year, as you know, and we are nearly up to the full recurrent cost in this financial year. So the risk around that is obviously that our income flows through our long-term agreements, so it's dependent on us delivering activity beyond the 1920 baseline activity in order to fund that capacity. And at the moment, there is for this financial year a small gap between that I'm forecast between the demand that I'm forecasting for the end of the year and the income we'll get for the whole year versus those costs of around 500,000, which the trust is currently having to manage within its own overall position. So I'll stop there and I'll take any specific questions either on the cover paper or the detailed report, either for the trust itself or TCS.
Stephen, I think you just picked Vicky to the post. So I'll pick you first, Stephen, and then Vicky, and then Martin. Stephen, please.
Thank you, Matt. It's not probably a question for yourself. It's actually probably more a question for Carl. Coming back to the energy costs, I know that the Trust already would have a programme of energy saving initiatives. And as those initiatives or opportunities are examined, there's a calculation, how much is it going to cost? How much is it going to save? And I'm just wondering, as we're now moving into significantly increased energy costs, whether there's any look or revisit of schemes which might not have worked financially before, but which might work financially now we're seeing these large increases in energy. And I guess it's more a question for Carl and yourself.
Yeah, it's a really good question, Steve. Two things or three things. First of all, in terms of the organisation, because of the demand for services, energy requirements are going up, aren't they? We just think about the Linux, for example, 8 to 10, and so that's the first thing we're going to recognise. It's almost an exponential reduction then in the cost. The second thing is what are we doing with the things we know now? So there's some longer term things around the new schemes which will be energy efficient, but they're about 3 or 4 years away. So that does form A, part of our energy reduction, and B, part of our decarbonisation strategy. See, there's some things we can do which we haven't yet funded. So for example, simple examples around metering. So we know that in the capital plan for this year, next year, and how can we get all of our things metered so we actually understand the demand and how we then make interventions around each of the particular sites. The last question, I don't think we've properly addressed in terms of where those schemes might have been previously considered for, in layman's terms, below the line, because if then cost benefit now tips at the other side, then that becomes a far more viable financial scheme then. So I don't think we've done that level of ask that you've just described. So we will go away and do that, because also what we're with Matt and colleagues at the minute, there's some discretionary capital available potentially this year as well. So we're going back around our below the line schemes over the next couple of weeks. So I think your point is really well made. At the minute, I don't think we do that sufficiently. I think we need to go back around that, Matt, and just get your sense of that.
Yeah, well, I was going to make the same comment as you. The conversations I've had with the estates team is around the first thing to do is metering, because we do not understand the opportunities where we can actually reduce volume. And until we get meters in a lot more places across our estate, that will give us the intelligence to sort of understand where we focus on when heating is turned on and off, where there's a comparison also with utilization of the estate. So how many people are using that area, and we're putting the heating on full blast, and there's occasional people coming into that area. So combining that intelligence with the utilization and the metering is essential, and that's the first bit of work. And we have got a revised bid that's going into Welsh Government, because they are now in a better place capital wise this year, and they've actually asked for new bids to come in. So hopefully that will be one that we can progress. I mean, obviously other opportunities that other health boards and trusts have done. There are solar farms, for example, that Swansea Bay invested in, but I think they're bigger schemes that will cost a fair amount of money. And I guess we need to consider, with our new hospital and the infrastructure work at WBS, is that really something we would be considering at this point? Probably not. So it'll be the things that you've asked us to look at, I suppose, that Carl will go away with the estates team and maybe actually think about some of the other things that we might have had in a pipeline that were shelved because we didn't have the capital.
Two other points, I guess there's the future of our estate as well, in terms of some of the work that Sarah and colleagues on hybrid working, because the other sort of funny position we find ourselves in is we've got a relatively small estate anyway, but because we had to work from home during COVID, and we still got relatively small levels of utilization occupancy in our existing buildings, yet they're still lit and heated. So once we understand what the future work looks like, we can then perhaps take some rational decisions about reducing the size of our estate and our energy cost. That bumps into some of the things we described previously around cost of living and poverty and all those sorts of things, where some staff might not be able to potentially afford to work from home and live. So all these things are sort of moving around at the minute, but I think we can do the obvious things, the scientific things about metering, and then I think Sarah and colleagues will work through what does agile working look like and how can we find the right balance. And we haven't even talked about sharing estates, sharing assets with other public sector organizations. So we've got to really get into that, because if nothing else, the cost is going to exponentially increase certainly in the next 2 to 5 years, isn't it?
Thank you, Carl and Steve, for the question. Ricky, your hand was up, wasn't it? Yeah. And then
Thank
Martin.
you. Just a question about the COVID-19 funding, and we talked about this in QSP, but I guess we're moving into October, which is month 7. And I guess the concern about contingency plans, if we were not to get the funding, we've got less time. So have you rethought that, Matt, in terms of actually what we'd be able to do?
Yeah, thanks. So all organisations have got to lock down their forecast position at the month 6. So that's a requirement. Welsh Government in terms of what that means, our forecast. So clearly, as a group of directors of finance working with Welsh Government, we're going to be obviously putting the challenge back to Welsh Government, saying, well, if you're expecting us to firm up our forecast figures, they need to be more firm around the COVID costs. Clearly, I'm fairly confident actually on the COVID response. They've been funding us those costs throughout the year. What they're expecting to see is reduction. So actually our part to play is more about making sure we're doing everything to reduce the costs where we can. Okay, so rather than worrying about what Welsh Government will fund, so as a responsibility for this organisation, and we have demonstrated since the beginning of the year, you know, gradual reductions in those costs, taking out the COVID response costs that don't need to be there anymore. So that's the bit I think we need to play, and we will get assurance from Welsh Government around the income. The COVID recovery capacity is an ongoing issue. Again, it's about us doing the things that were actually reported in the performance report about the improvement in the radiotherapy performance. So because that is the main area of concern in terms of our income versus the costs that we've invested. Once that gets back to the 1920 levels, again, we will be in that tipping point of we're break even on that income versus cost. So but the point's a valid one, and in terms of measures, the measures that are new, and well, most DOFs around any NHS organisation will use is balance sheet flexibility that we have, that we may end up having to play into the position should we have to take some of these risks, and we have got that non-recurrent opportunity that I can use.
Which means we're still predicting a year-end break even.
Yeah.
Yeah. Thank you, Martin, please.
Thank you, Chair. Yeah, Matt, I think the predicting a break-even position for the year is even more remarkable when you consider the pay inflation, which may or may not be funded by Welsh Government, energy inflation, and general cost of living, which is going to push up the cost of goods and services we're buying as well. So I'm hugely impressed, but a little nervous, because inflation is running at quite high rates at the moment, and that's going to mean all our contracts are going to be going up as well, aren't they? Although they're just everything we buy, so it's a concern.
No, that's correct, and not, I suppose in terms of our if you take out the big contracts on terms of our non-pay, is not a significant sum. When I say that, I mean excluding also the 60 million on our drugs, which is a pass-through cost. So certainly the IRS contract, as you know, had a fairly sizable hit because of the 10% inflation it's running at, and because it's a CPI inflated contract. So, but our commissioners have been fully cited on that and recognise that ask over the next 3 to 4 years. Now, you know, obviously it's going to be a financial challenge for them to find that increase, but they have recognised it in the business case that they've well, hopefully I'll be signing off in the next week.
Yes, sorry, Lauren. Yes, please.
Yeah, because that exact question is something we were talking about in Executive Management Board on Monday, Martin, which is what percentage of our cost base is actually subject to interest rate risk. So Matt said, it's a really important well, we didn't think we get an actual percentage rate, but the concept of the pay plus the pass-through costs and then what's left.
Yeah, so on the assumption that Welsh Government fund the pay award, whatever that might be, because obviously, you know, we're still in negotiation, aren't we? So no, okay. Well, I'm not sure I've had an announced pay deal. So
we're still in negotiation. We're not in negotiation, it's been awarded, but okay. There are.
Okay, sorry, wrong terminology.
There's
I haven't had a notification from Welsh Government saying this is what we need to uplift pay on.
That's right, but, which we had reported here.
Okay.
What we don't know is coming down the line at us is what industrial action could.
Yes.
That could throw a curveball at all our figures, couldn't it?
So what I'm saying is there's still risk in that area of our cost. If you take out all of the other big costs like NICE, that is a pass-through risk to commissioners, so they have to bear that risk. So, you know, what we're describing is the non-pay that's left is not a huge figure, but it is subject to 10% inflation.
Mhm. I can't see any other hands up. Just to note for the minutes that Kath O'Brien has had to dip out and she will hopefully rejoin us shortly. Do you want to, so that covers my month 5. Do you want to go through the detailed paper, Matt? Or can we go on to the TCS programme?
I don't go through any of the detailed papers. They're really for information.
No, okay.
Because QSP committee have the opportunity to fully delve into the detail, but I'm happy to take any questions on them now.
So the TCS programme finance report is there, as well as the detailed M5 Velindre NHS Trust financial report. So if there aren't any further questions, we note, having discussed those reports, that we note them. Thank you very much, Matt. Interesting times. So we now come to section 4.4, which is the Trust Risk Register. And I think, Lauren, you're introducing this item to us. I'll hand over to you, please.
Thank you, Chair. So if we could go to section 2.1 in terms of the key points for the board today. So the review of the Cancer Centre risks continues to be a focus of the senior leadership team. And if Kath was here, she could provide some more detail as to how that's actually playing out in terms of the time they're spending on this. So in terms of workshops and an away day this month. And they there's a commitment by the next reporting period to have all of the action plan boxes for in Datex completed for these risks. We spoke about it at board previously as to whether there was just an error in the way in which Datex was being pulled through. So hopefully that's clear in the reporting now. So where there's blanks, there are blanks, but they'll be completed by the next reporting period. Migration onto Datex 14 is complete for Welsh Blood Service risks, and the risk management policy is the third sort of key item for today. So this was considered at the audit committee, and the audit committee requested to have sight of the other parts of the framework that the policy was part of. So the risk appetite strategy, the trust assurance framework, and the procedure. So on that basis, Martin and I spoke on this, and the audit committee, having even though it's meeting on Tuesday, but Martin was comfortable that the audit committee, that action had been fulfilled, therefore it could come for board approval today. So that's in Appendix 2. Also, just the other point I wanted to say was we've only had a draft audit at the moment from Kate and team in Audit Wales in terms of the quality governance audit, which we're responding on. But there are a number of really helpful comments in there around our approach to risk, and we'll work on those and reflect it in the next period. But one of those is that as a whole, rather than focusing on the process itself. I know that's something you were very keen to emphasise as well, Chair. So on that note, happy to talk about any of the process points or anyone around the table on the individual risks.
Thanks, Lauren. I think, we have been working hard to get the process right. So I don't want to beat ourselves up too much on that, because if we didn't get the process right, we could miss the mark on the content. But quite right, I had a discussion with Lauren over the last couple of days to say we now need to focus on the particular risks that cross a certain threshold as much as the process. But I'm very pleased to note the progress that we've made with the process for how we populate our risk register. So I'll hand over to you first, Martin.
Yeah, thank you, Chair. As Lauren said, we had a discussion about this, as you saw in the highlight report of the audit committee back in July. And I think that, Chair, your comments are exactly right. In the risk is you spend your entire life worrying about the process and not worrying about the risks. And clearly the process is just a tool to help you think better about what risks we are facing as an organisation and how we can respond to them. So I think this is a very solid piece of work. No, it's better than that. It's a very good piece of work. And I'm very happy that the audit committee's had the opportunity to discuss and air this, and we had some out of committee discussions as well since then. So I'm very pleased.
Thank you, Martin. Vicky, and then Stephen.
I think particularly on the risks themselves rather than the process, in QSP we discussed the range of digital health and care record risks that are highlighted here, and all of the detail as we discussed in QSP isn't here to understand the range of actions, but I think it is knowing that those actions are in place to assure the board, because obviously there are some that are of concern when you read the narrative, and it's just understanding that actions are in place to mitigate those risks that we wouldn't be able to have summarised in this table.
That's really helpful, Vicky, I think. Thank you.
Thank you.
Stephen?
I just want to pick up on one of the particular risks which is mentioned here around the palliative care training posts. I'm going to refer back to Matt's finance report. In the detail of the report, there was a paragraph referencing the challenge of filling the junior doctor posts. So this, again, it's not a question for yourself, Matt. I'm just wondering whether Jazz and or Nicola, if you just want to give a brief comment to the board on where we are with appointing to particularly junior medical staff posts and the challenges of that, and if there are any issues that you might want to draw to the attention of the board, recognising, of course, we do have a more detailed discussion at QSP, but I just thought, as it was mentioned in two different spots, might just be worth a quick comment from yourself.
Thanks, Stephen. Jazz, do you want to respond to that?
Yeah, I mean, I think that this has been a kind of long-standing issue around junior doctors who have kind of short-term contracts with us at Velindre. I think most interestingly, in the last 3 years, we've had, in a sense, an over-prescribing or subscribing of people wanting to come and work in Velindre, which is a really positive fact. There's never any sort of assurance that that will continue. So there's always a kind of risk around that. We have been in a situation possibly about 5 years ago where we were not able to appoint. And then that has an impact on our vulnerability, maintaining our rotas, out of hours in particular. And it's difficult to find other groups of staff to perhaps substitute that. What we have been doing, it links in with the earlier conversation around SAS doctors, is to actually sort of use a strategy of having a number of specialty doctors at any one time employed by the trust who can also buffer that junior doctor cover, if you like. And the other initiative that's also happened is around international recruitment. So I think these are some of the things that we've been looking at, which are trying to mitigate the risk. I think Nick's going to probably come in to say that there is also an initiative to upskill our very expert nursing colleagues and AHPs, and the reliance on junior doctors also becomes less significant as we go on, and particularly if we look at the way we run our assessment unit, we have very expert ANPs who are managing patients largely on their own. There will always be, however, I think, a requirement to have a particular number of medical staff on call, and that is something that we're mindful of as we're moving to the new hospital as well. How do we ensure that we have a robust, sustainable workforce to do that?
Nick, you wanted to come in to respond to Jazz?
Yeah, I wanted to come in on the point that Jazz has raised, and I think we're embarking on a journey in the cancer service and Welsh Blood actually on what our workforce for the future, and I mean medium-term future rather than long-term future, needs to look like, and that will be different from what it is now. So we are just, we've received a new national advanced practice framework that we just translated into, well, what does that mean for Velindre? So that should be drafted by the end of November, and we are engaging in looking what is the team around the patient. So what is it that we need? Using the principles of do things well, do it once, and that would be a different team than what we've got at the minute. So lots in this space, and Jazz and I are working, very closely on this together. because I think what we needed in the past and what we need in the future are going to be different.
Thank you. Are there any other of the risks that are rated over 20 that anybody in particular wants to discuss this morning? Lauren.
Just say apologies to Vicky, because Kath did reference it earlier in the meeting that when we reach the risk paper, she was going to talk about the digital health and care record risks.
Yeah.
So I should have clocked it and acknowledged the QSP discussion. So thanks, Vicky.
So I think as a general point going forward, where we've had a thorough discussion of these issues, could the cover paper reflect that we've done that?
Yeah.
And then I think that will be really helpful.
Yeah.
It'll avoid us having, for the sake of demonstrating that we've sought assurance, if that cover paper contains the challenges that and the observations that were made, or a summary of them.
Yeah.
Because if without that, and if we don't discuss, because we had very thorough discussions on all of these, it appears though the board isn't taking these red risks seriously. And of course the board is taking it very seriously through the work of the Quality and Safety Committee.
Yeah, and I think just to comment on that, because I think we've got a paper later on in terms of the ventilation capital scheme, and there it summarises the QSP discussion, which is helpful.
Yeah.
And I think it would be helpful, as you say, that we do that in these papers. Thank you.
We have to make sure there's sufficient time between QSP, which I think we've started to do, and the board to enable officers to do that cover paper. Otherwise, in order to demonstrate to the public the governance, we will have to re-rehearse the arguments, and we don't want to do that. Lauren, are you content for me to move on?
Thank you so much. Yeah.
Thank you. So we come to 5.10, which is we've got 2 annual reports to look at. Let me just find them here. One is health and safety, and the second one is Welsh language. So, Carl, are you going to introduce the health and safety, please?
Yeah, thanks. Just a couple of sort of introductory remarks, really. Firstly, I think it's been a positive year. I think good, strong progress has been made over the year in 3 or 4 areas. One, leadership, health and safety, systems and processes, training and culture, reporting, and learning improvements. I think it's been a strong year, which continues to improve. Second point I'd like to make, I don't particularly like making thanks to you, miss people out, but there are a small group of people who are really helping us to move this forward. Helen Jones, Kerry Pell Stewart, Buswell, Robin Weaver, Matthew Bellamy and Paula Jones. So special mention to those individuals, not me leaving people out, but they really have been a real force for good and critical mass. Third point, I think just drawing the board's attention to, I guess, some opportunities for the future. So there's a couple of things which leap out at me. If you look at the incidents and the incident type, about between 30 and 58% of them are accidents or injuries. So there's a missed opportunity to stop them happening. And the second one, clearly, is around training compliance. You know, still improving, but a bit to go. And imagine if we get up to 95, 100% compliance, and what that might do for the safety of our staff, the patients and the donors. So I think some opportunities to go even further, but happy to take questions on the report.
Thank you, Carl. Are there any, I think those are 2 points very well made. Any other issues to raise on the annual report? Thank you.
Sorry, Chair, I've got my hand up.
Oh, sorry, Hilary. Apologies. Hilary, over to you.
Okay, thank you, Chair. We received this report in QSP, and there was I raised a query at that meeting, which I thought might have found its way to the report, but I don't think it has. I just wanted the board to have the assurance that all the electrical safety and water safety is all up to all the assurances should be given to us that all those testing and stuff is done. It makes reference in the report about that there are groups looking at this, but it doesn't give us the assurance that those testings are done. So I just thought it might be useful for Carl to reiterate to the board that they are all in place. Thank you.
Yeah, apologies, Hilary. My oversight, so I do apologise. That's not featured in this report. I'll drop the board a note after the meeting, if I may, just to, because I want to make sure that I give you the absolute accurate position rather than saying yes or no right now. So if the board are happy, I can circulate a note which addresses your particular question, Hilary, if that's okay, Chair and Hilary. I don't have Jason next to me, so I would normally turn to Jason, who's my expert. And without that, I'm just a little bit reluctant to say yes or no right now. But I'm hopeful, Hilary, if that's okay. But I can certainly get a note to you first thing next week, if that's okay.
Yeah, that's fine.
Thank you. Is that okay, Hilary?
Yeah, that's fine. Thank you, Chair.
I think the point that I've noticed in the subtype graph is that the number of needle stick medical sharps injuries is the largest component of accidents. So that warrants a little bit of discussion and thought. So
Just a
sorry,
very brief comment, if I may, just on the violence and aggression, very low levels, but I think I always wonder with these sort of things where the threshold is, and actually it's rather
wait, sorry, Andrew, where the what?
the threshold for
sorry.
reporting that is, and it does sound from what's here as it is frustration on the side of patients, then it's verbal aggression, it's not physical assault, and I think so reading it at first, even at low levels, does provide a certain amount of worry, but I think it does sound like it's people venting their frustration on the whole, right? If I'm reading that correctly.
Nick?
Yes, and having received all datexes for the organisation, I can confirm that that is absolutely the case, and it's great that we actually don't see the instances of physical aggression, and it does tie in with our communication theme that we see through complaints as well, and I think some of it is, you know, communication or misunderstanding, but yeah, it is generally frustration that has resulted, and I think it's very difficult to know what isn't reported, isn't it, within this space, because you know, thresholds do vary, but I think we have got a healthy reporting culture around this type of thing in both Welsh Blood and the Cancer Centre.
Thank you, Nicola. So we approve our health and safety annual report, and then we come to 5.20, which is the Welsh language report, which we have presented to us in both English and Cymraeg, which I'm very pleased to note. Sarah, are you introducing this?
Yes, thank you, Chair. So this is our Welsh language report, annual report, which we're required to produce and publish, as you can see. I'm very keen that through this annual report, what we're doing is presenting against those areas of work which show our compliance with Welsh language standards. Also, of course, the more than just words framework, which we're required to comply with, which comes from Welsh Government, which has been actually reviewed and republished this year, but also takes a step back and actually considers the broader picture, which is where we're calling our Welsh Cultural Plan, to actually understand what is it that we're actually trying to achieve here, because we're not actually ultimately about achieving Welsh language standards or the more than just words framework. We're actually about providing the best environment for patients, donors and staff who want to carry out those activities through the medium of Welsh in a bilingual country. And I think that's a very important underpinning statement for me that we've always got to keep in the back of our minds when we talk about compliance. So what we can see here in the annual report is that we have outlined the progress that we've made against a number of those elements. What we know is we've got lots more work to do, because this is a very, very difficult area for us. We've got our governance processes in place. We've got the working groups in both operational divisions. We've got our Welsh language development group happening across the organisation. We've got our ambassador in Steve Ham as our chief executive.
Yeah.
And we've got our IM champion in Gareth in terms of Welsh language. What we do know, however, is that on the ground, actually making these things come to life is very, very tricky. So when we talk, for example, about every piece of literature that we have, every letter that we send out, that they should be available in Welsh and English. That's very, very difficult to do through our IT systems at the moment. And you can see some of that reflected through here. We also know now that we've moved to a place where we are Welsh language assessing every vacancy that comes through our recruitment process. So that is happening. We also know that we should be translating every job description that goes on our on NHS jobs. We are not able to comply completely with that at the moment because service pressures mean that we haven't got the ability to translate in enough with enough speed to not hold up some of our key recruitment priorities. So we've constantly got these competing levers, as colleagues will be aware, through the organisation. That doesn't mean that we're not looking at every one of those with a great deal of urgency to see how can we improve and how can we make sure that we are prioritising where we need to. We have had some complaints over the year and we're continuing to learn from those, particular kudos to Welsh Blood colleagues when it came to a piece of information we received about the website and how we can improve that in terms of its bilingual offering. And, you know, colleagues there responded very speedily, very quickly, and have added a lot of value to the response that they've put in place and the actions that they've put in place. So I won't say any more. There's a lot of information in here. Nice. And what we did have was a good conversation at QSP, and you'll see from the QSP highlight report that Welsh language was one of those themes that played out through the meeting, actually, through a number of different areas of work. We know we want to ultimately aim for Welsh language speaking staff on every shift, in every area and in every service. We are not there yet. We need mechanisms in place to enable us to get there. And I think that's some of the feedback we're going to bring back to QSP next time to actually have another conversation about that. So I'm happy to take any
Thank you, Chair. I
questions,
think this is an authentic report. And by that, what I mean is it hasn't tried to gloss over anything. You know, it tells the story as it is, and I commend you and the team for that. It is truly an authentic report and shows how far we have to go. I've just got two quick observations, if I may. Martin, I'll call you in just a sec since I've started. The last paragraph on the introduction by the Chief Exec, where it says the ethos of a new cultural plan was accepted by the executive board, I would have liked that to have read the board, that the executive team feel that the whole board is behind you on doing this. So I wondered why you think the board wasn't behind you. So and then the other fine, could Sarah, the penultimate paragraph on page 3, which is to do with Welsh Blood. We go back to it. Page 3. The penalty monitoring telephone calls to and from the trust is extremely challenging. Do you mean monitoring which telephone calls are conducted in Welsh?
Yes.
Is that what this means?
Well, what this is talking about is how we're able to respond to callers who want to speak Welsh when they're making that call.
Yeah.
So monitoring, I suppose monitoring is probably the wrong word there then, isn't it, in that respect, isn't it? It's actually responding to telephone calls that we receive in Welsh.
In Welsh, yeah, because because at Welsh Blood Services is more achievable than it is in the trust as a whole. In this reporting year, calls to the donor collection team was 1,004. Does that mean 1,004 in which it was a Welsh language required? It doesn't actually say that in that paragraph, I don't think.
Right, okay.
So before we approve it, just to make that clear, that is specifically around calls and where the caller required a conversation in Cymraeg. Martin, please.
Yeah. A couple of things, not to change the report in any way, but I'm really pleased to see the statistics about recruitment in Welsh language. Then the section about educating the existing staff is a bit fluffier. There aren't numbers in there about how many staff we are training, although it hints that it's not as good as it could have been. So I think there's something in there. And just a wider point, it's really important that we deliver services and we are able to communicate with patients and donors in the language, their first language. And of course, that isn't just English and Welsh. When we have, for example, the new Ukrainian refugees coming in, they might need support. So, I mean, there's a whole issue of translation services more widely than just English and Welsh, I guess. It's something to think of. Yeah, thanks.
I think that last point is point well made, but doesn't come under the kind of statutory provision. So I'm sure we could pick that up perhaps as outside the meeting if we may. So I'm mindful that our colleagues have arrived. So can I ask, thanks Martin for those comments. Can I ask that colleagues that we approve this report? If you could just put a bit of clarification in that paragraph for me, Sarah. Can we approve this Welsh language report? Annual report, thank you. Got one substantive item left. Just wonder if we need to tell the people outside that we're nearly done. Which is 6.20, which is the capital scheme for ventilation. And I think, Carl, you're introducing this to us. A bit of context to this report, this paper.
Yes, Chair. So I'll do a couple of sort of headlines to start the discussion. Like the majority of the UK, the NHS estate is largely old, and it's quite difficult then to maintain it. Our ambition is always to ensure we achieve the required minimum standards. So the cancer centre is 68 years old, and the ventilation is not at the required standard, which is set out in the paper. We've been around this a number of times, and the board received this a couple of years ago and set two conditions to move the business case forward, which is in paragraph 1.1, and they're fairly important conditions, aren't they, in light of the COVID pandemic, about not losing any capacity to be able to treat people quickly and secure their prevention from infections. And secondly, understanding when the best time was to actually do the scheme, because it's going to take quite a bit of effort and approximately 48 weeks from end to end in an old hospital. So that's the background. I think the key points for the board to note, what's happened since. And if I take you to paragraph 2.1, and the Executive Management Board considered this again, mindful of the fact that time has moved on the 1st of September 2022. And it says there that those conditions still haven't been met, i.e. the prevalence of COVID, and we're just about to embark on the winter season plus flu, and together with essentially finding the right time to do that in terms of not reducing capacity to treat patients. So that's in para 2.1. And then secondly, also recognising some of the things that have moved forward in terms of the certainty around the new cancer centre, the evidence at this moment in time suggesting that the interim arrangement is sufficient and it hasn't resulted in any additional harm. And then finally, the last test is the value for money test, whereby by the time we were able to do the scheme, it's very likely that we would broadly be moving out of the existing hospital into the new one. So in terms of value for money of securing that asset, the Executive Management Board arrived at the conclusion on balance that it was probably not right to proceed with the scheme, but it was right to further enhance the existing interim arrangements and make them more permanent. This was discussed, it says there in paragraph 2.4, the Quality Safety Performance Committee in some length, and I've tried to capture that discussion. So again, the board's asked really to now not take forward the planned scheme, given the things I've just outlined, but actually make permanent some of the interim arrangements, which do certainly give a benefit in terms of temperature control and also add to our infection prevention control arrangements. And the annex one there is just a bit about the cost benefit we will go through to determine whether we continue with the revenue of renting that equipment versus the purchase of it through capital. So I hope that sort of succinctly summarises probably something which has been about for about 2.5 years, but is still difficult because of COVID and other matters. Thanks, Chair.
Vicky, please.
I think just to pick up on that final point that Carl was making, because when the QSP considered this, it was being asked to endorse it for the capital scheme for ventilation. I'm unclear now, just based on what you're saying about whether the exec team discussion took place after this committee, because what we said is that we were endorsing it on the proviso that a cost benefit analysis would be included within the board papers. This makes reference to appraisal will be undertaken rather than has been undertaken. and then the recommendation at the end, which is saying that we don't get that progressed. So the board is asked to approve, and then it says that that the ventilation scheme is not being progressed. And I'm confused with the conversation back in QSP, if that makes sense, in my confusion.
Yeah, I can hopefully tidy that up fairly simply. So I think there's two separate things there, Vicky. Sorry if it was confused at the committee. The first major decision is whether the board wishes to go ahead with the permanent £2.2 million ventilation scheme. So that's the decision. The second one then is if we don't wish to go ahead, it's how we then continue to implement the existing arrangement, either through a revenue or a capital. So I think that's a second order issue. The fundamental decision of the board today is the recommendation is not to spend £2.2 million for the reasons we've discussed. So that's the key decision I'm seeking from the board today. And then the second one is, what's the best way then to continue to use the interim arrangement? Is that through a revenue stream, or is it through purchase of the capital equipment? So apologies if that wasn't sufficiently clear in the committee.
Thank you. If I can just come back, I think that helps in terms of clarity. I guess the board paper doesn't include the cost benefit analysis, which was undertaken to be made in QSP in the board paper.
Yeah, just to come back. So the whole putting these things on and off. It's not possible right now because until we actually decide which solution we're going to go, we won't go out and get some tended costs. Spoken to Jason. So the indicative costs are here on the capital equipment and what we've got in terms of spending on revenue. Until we actually go out, we won't be able to give you precision. So it's just it's a timing issue. I mean, I don't think it's my personal view. It's not material to the first decision, which is, do we want to stop the £2.2 million scheme or not? The second one then is an important point as well in terms of securing best value for money. So I think they're related but separate. And this paper perhaps hasn't teased that out sufficiently. So I apologise for that.
I can't see any other hands up, so I'm just going to take us through what we're asked to do, which is to note the progress to date, note the professional advice and the assurance provided in respect to the final contract. No, wait a minute, I'm looking at the, I was just trying to sort out part B and I picked up the wrong paper. I'm so sorry. So what we're asked to approve is the business justification case and planned capital ventilation scheme is not progressed. Can I ask, first of all, for the board's approval on that matter? Yeah, our director of nursing is nodding as well. That's very important to me because it's about patient comfort and experience. It's also about control of infections. So if you're content as well, that gives me great comfort. And Jazz is nodding, I think. And then secondly, the current solution is made permanent with the optimum option deployed following cost benefit analysis. But we need to complete that in a timely manner so that whatever we're going to introduce is introduced in particular before things start to heat up again in the spring.
Absolutely, yeah, absolutely.
So that's approved as well with that caveat that I just introduced. So that takes us to point 7. I haven't been informed of any other business. So does anybody want to raise any point on any of the items we've discussed today? I don't want anybody to go away saying, I wish I'd said such and such, I wish I'd observed whatever it might be. And you missed the opportunity at the time. I'm giving an opportunity now that any point, I can't see anybody. The IT support. No? Then in which case I propose that we close this public board meeting and we adopt the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest in accordance with section 1(2) Public Bodies Admissions to Meetings Act 1960, section 67.